Can you see our screen?
Yes.
Okay. So here we are.
Okay.
No, sorry. Sorry.
Cosa c'è che non va?
Perché questo non la vede. Oddio. Questa sì. Can you see our screen?
Yes, we can see it.
Okay.
Okay, we can start?
Yes.
Okay, thanks a lot. First of all, we really would like to thank Professor Comi and all the organizers for having invited us to teach this lesson. Let's introduce myself. I'm Maria Sessa. I'm the director of the neurology unit here at Papa Giovanni XXIII Hospital in Bergamo. With me, Simonetta Gerevini. She's the director of the neuroradiology unit and of the Department of Radiology in the same hospital. Simonetta and I are bound by a long-lasting friendship and collaboration that dates back to almost to the last century, when we were moving our first steps for professional steps together at the Scientific Institute San Raffaele in Milano. And so it is really a pleasure to share this presentation with her. This is the outline of our presentation. I will start trying to clarify what the term leukodystrophy refers to. Then we will go through the classifications of leukodystrophy. I will try to discuss the diagnostic approach to a patient with a suspected leukodystrophy from a clinical point of view. Then Dr. Gerevini will provide a kind of structure approach to imaging and describe the radiological features of the principal leukodystrophy. And then if we don't run out of time, we have collected some clinical vignettes and a few slides on therapy. So if we want to find the term leukodystrophy, we have to go back more or less 1 century. The term was used for the first time in 1928, and it was used to define a family with metachromatic leukodystrophy, and it referred to a disease which was hereditary, progressive, and characterized by white matter degeneration. The term was used more or less in the same way up to the 80s, with again leukodystrophy were considered genetic, progressive disorders and primarily affecting myelin.
Excuse me, for me, the presentation seems to be stuck on the same slide. I cannot see the different slides.
Yes, that's the same with me.
Yes,
we are moving on. We are moving on with our slides. Maria?
Yes, I can see the same. When we tried, it was not stuck. I can try again to present if mine move. But or maybe you can try just to present again.
What if we move here? No, don't.
Yes.
What now?
Oh, no. It's the same. The first slide.
It's the same?
The same slide, the first slide,
Okay.
yes.
And if we do in this way?
Yes. Then we can, yeah.
Okay. Sorry, it is not perfect, but anyhow, it's functional. Okay. So at the end of the past century, the white matter disorder were further characterized in 4 categories. The hypomyelinating disorders, in which you observe a lack of myelin deposition. The demyelinating form, in which you observe the loss of previously deposited myelin. The dysmyelinating, where the deposition, you observe deposition of myelin, which is abnormal from a structural or biochemical point of view. And the myelinolytic diseases, where you observe myelin vaporization. You see the next one?
Yes. Yes,
Okay,
yes, you can
okay.
see.
So, of course, every classification reflects the knowledge of its time, and the introduction of magnetic resonance in the 80s and of NGS next generation sequencing in 2000s really has literally revolutionized the clinical and our clinical practice and the approach, in particular in the field of genetically determined diseases. Okay. We had to wait till 215 to find this first case definition, which was proposed by van der Verer and all her collaborators. It was the case definition of leukodystrophy and the classification which tried to differentiate between leukodystrophies and leukoencephalopathies. Again, leukodystrophy was defined as an hereditable disorders affecting white matter of CNS with or without PNS involvement. In this definition, it has made well clear that leukodystrophy did not include all the acquired CNS myelin disorders, CNS diseases in which the neuropathology were showing a primary involvement of neurons in cerebral cortex or other gray matter structures, the inborn errors of metabolism in which actually the clinical manifestation, the systemic clinical manifestation usually predominate on the CNS manifestations, and those disorders in which the involvement of the vascular system, in which vasculopathy was a primary disorder. It has to be underlined, therefore, that the definition does discriminate on whether the disease is primarily a glial cell disease versus a systemic disease, and discriminate based on which cell type was involved. Therefore, for example, all the diseases in which primary gray matter or neuronal disorders were the prevalent involvement were not classified as leukodystrophies, but it was coined the term genetic leukoencephalopathies. The definition does not include the organelle that is involved. We were used to differentiate these disorders, for example, lysosomal, peroxisomal, and so on. And one term which was excluded, and you won't find it anymore in the definition of leukodystrophy, is progression. You will say later that some of these diseases do not progress, or at least progress very, very slowly. This classification was based on a round of surveys among worldwide experts on genetic disorders. There were 4 rounds of surveys. A group of leukodystrophy reached a consensus, a 100% consensus at first surveys, other just at the following surveys. Altogether, 30 diseases were classified as leukodystrophies. My screen doesn't go on anymore. Okay. These are the list of the 30 diseases which were classified as leukodystrophies, while the other diseases were classified as inborn errors of metabolism, vascular disorders, I guess there is, okay, mitochondrial disorders, or others. Just a few years later, Mario van der Naap presented a new proposed classification. For people working with genetic disorders, Mario van der Naap is the worldwide recognized authorities on white matter disorders. And this classification was proposed based on 3 cardinal aspects. First of all, they applied a very structured approach to MR pattern recognition, and we will see later on with Simonetta how relevant the recognition of specific MRI pattern is crucial for the identification, for the differentiation between genetic leukodystrophies and acquired disease, and for the diagnosis of specific leukodystrophies. The other relevant point, of course, was the massive increase of new information thanks to on genetic new gene, on genetic defects, thanks to the introduction of NGS. And again, the dramatic increase in knowledge of the complexity of white matter, and the acknowledgement that for integrity and function of white matter, a real teamwork is required. And according to the new definition, we now recognize 5 categories, which depends on the primarily cell involved. So we recognize myelin disorders where oligodendrocytes are primarily affected, astrocytopathies where the defect is in astrocyte, leukoaxonopathies where the primary defect is an axonal or neuronal defect, microgliopathies, where the defect in a microglia-specific gene, and last, disorder due to vascular pathology defined as leukovasculopathies. This is the table that I took just from the original work of Van der Napp. And as I said, the classifications are colored by the knowledge of the time. This classification was published in 2017, and just a few months ago, a review and the new classification of primary microglial leukodystrophy was published thanks to the identification of 2 genes. So it's a continuous change, a word in continuous modification. And the new disease was identified. Let me pass to the next one. This is the only disease associated with the lamin B1, subunit B1 defect. It is a fatal autosomal dominant leukodystrophy. Okay. Not all the diseases we see listed in these quite complex tables have an adulthood onset. The majority of them have a very early onset at birth or in the first years of life. Just a few of them have a late onset, and I try to list them according to the Mario van der Napp classification in this table. And in the right column, you have the gene defect associated with the disease. I bet that you are asking why the classification of leukodystrophies is so crucial, because in some way, a classification encapsulates what we know about the pathological mechanisms underlying the diseases. And this is, of course, a very relevant implications for therapy, because we have to know which is the primary defect we have to target with our therapeutical approach. So, as Mario van der Napp says, we have nothing to gain from oversimplification, because we are taking the risk of missing out what we really needs to be achieved. Okay, so we now try to, I will try to give you some clues and some suggestions to how differentiate what are the characteristics that usually help us in differentiating a genetic disorders from an acquired one. I want to underline that I said usually, because not these characteristics are not always present, and so can sometimes a genetic disorder can be misunderstood as an acquired because it is just lacking part of these characteristics. We have said that we are dealing with genetic disorders. They have a pattern of inheritance which can be an autosomic dominant, autosomic recessive, or X-linked. Usually what you observe in the autosomic dominant diseases, you observe a vertical transmission pattern. So in the family, you see the presence of affected grandparents or parents. On the contrary, in the autosomal recessive diseases, you observe a kind of horizontal pattern in the sense that you can observe more siblings more affected, more sibling affected, and with a negative family history, no parents, no grandparents. In general, in the autosomal recessive diseases, we know that there is a kind of consanguinity among parents. It is important to recognize that this consanguinity cannot be so apparent. We used to consider also, we need to consider also what we call a geographic consanguinity, which is typical, for example, of islands or of this region. We are in Bergamo and we are surrounded by small valleys. And usually what you can observe, we have the opportunity to see a lot of genetic disorders in this area because there is a kind of consanguinity among ancestors. They have common background, common ancestors, the parents. And the other point, you have always to remember that these diseases can have an incomplete penetrance or the possibility of de novo mutations. Therefore, some affected patients will not have an evident family history and may appear to have just sporadic disorders. The other thing to remember is that we have to debunk some way the assumption that female carriers are asymptomatic. Usually they are asymptomatic at birth. They can remain asymptomatic in childhood and adolescence, but then they present in adulthood with slowly progressive symptoms, typical in the variant, the SPG2 variant of Pelizaeus-Merzbacher. Patient present with the progressive spastic paraplegia, as well as the female carriers of XALD. They present in adulthood with symptoms of myeloneuropathy. Age, usually these diseases are classified according to age of onset, early infantile, late infantile, juvenile. The adult cases, the cases are defined adult when the onset is usually after puberty. There are quite disagreement with this classification according to age range because a lot of reasons. The principal one is that onset is not always easy to identify. In some cases, initial symptoms can be very subtle and therefore underestimated and misdiagnosed. On the contrary, when you have a positive family history, you can overestimate some symptoms and therefore you can anticipate the real onset of the disease. And this is its consequences, as usually onset of the disease is used as a prognostic index. The earlier the onset, of course, the more severe the progression of the disease and the prognosis of the patient. Usually, the onset of the adult variant are in the third, fourth decade, but the very late onset cannot exclude white matter disease, a genetic leukodystrophy. This is just a report of a case of a patient with MLD presented at around 60s. And this is a nice paper on a large cohort of patients with an adult onset leukoencephalopathy with axonal spheroids and pigmented glia. And you see that the mean age of onset is 43 years, but there are a lot of people, a lot of patients with an onset above 50s up to 78 years, with again age of onset usually around second, third decades, but a very late onset does not exclude these disorders. Onset usually is gradual, slowly progressive, but not always. There are some diseases that can present in acute way or can have acute episode of rapid deterioration, usually following stresses, just as fever or minor head trauma. This is typical of vanishing white matter disease. They can be remitting. This is quite typical of megaloencephalic leukoencephalopathy with supracortical cysts and of leukoencephalopathy with thalamus and brainstem involvement and lactate elevation, or as we have said, can be non-progressive, and this is more typical of Alexander disease. The presenting clinical features, usually the most common presenting feature is cognitive impairment and or psychiatric disturbances. This is very typical of MLD. Could be a presenting clinical features in primary microglial leukodystrophies, less typical of other leukodystrophies such as vanishing white matter or GLD. You will see later on the MRI of patients with GLD, and you will understand why the presentation usually is with spastic gait. Always remember to ask if there is an history of learning disabilities, which sometimes can be underestimated. The other presenting clinical features, as I said, are disturbances in gait, spastic and ataxic, typical of GLD, typical as presenting symptoms, we have said, in females with SPG2 or carriers of XILD. Other presenting symptom can be just an additional note on women carriers of ILD, a symptom which is quite unusual in acquired myelopathy is the presence of fecal incontinence, which on the contrary was reported in a high frequency, in a high percentage of female, up to 30% of female with XILD. The other presenting symptoms can be bulbar signs, such as dysphonia, dysarthria, and dysphagia, which very frequently can bring to erroneous diagnosis of ILS. And the bulbar signs are really typical of Alexander. The autonomic dysfunction, which are typical of autosomal dominant leukodystrophy. Less frequent, the presenting feature can be sinus peripheral neuropathy. This is much more typical of early onset, therefore they are really more typical in patients with infantile onset, in particular MLD. In the adult is very rarely presenting symptom, and sometimes is not present at all the involvement of peripheral nervous system. When the PNS present is the presenting symptom, it can be misdiagnosed as for a Charcot-Marie-Tooth disease. Well, so we have our patient with, as we said, who present to us either with a cognitive impairment or with disturbance of gait. Of course, the first exam we ask usually is an MRI, and therefore I pass the microphone to Simonetta.
Thank you, Maria, and thanks again to Professor Comi for this invitation. When we look to leukodystrophies, we look to presence or absence to signal modification in the white matter, and it is very important for us to know that myelination follows an order, and as it follows an order, we can have a sort of predictable pattern. So tracks. As they become the tracks myelinated as they become functional, the PNS myelinated before the CNS, the sensory areas myelinated before the motor areas, the primary function areas myelinated before association areas, and most tracks myelinate in direction of impulse conduction. And again, myelination progresses from caudal to cranial, from dorsal to ventral, and from central to peripheral. So we should know all these things, and just knowing which kind and which part of deep white matter is involved, we can suggest a specific disease or another kind of differential diagnosis. It is very important because if you know exactly the most important white and gray matter structures of the brain that can be involved in metabolic disorder, you can go for a specific pattern recognition. So when we are dealing with presence of white matter hyperintensities on MRI, just looking at the distribution of this signal and intensity, so if it is if it involves the cerebellar region or the supratentorial region, if it is bilateral, monolateral, symmetrical or asymmetric, if it has a sort of gradient distribution, we just looking at this specific peculiar distribution, we can suggest if we are dealing with an acquired diseases or we are just looking to at genetic diseases. And in case of genetic diseases, if there are vascular presentation or if there is non-vascular presentation. So in terms of pattern recognition, we have to look first of all at the involvement of the white matter, that it is always symmetric. So we can see a symmetric distribution of the hyperintensity on T2 and flare, that in some cases it is associated to hypointensity on T1. The signal involvement can vary according to the cause and to the stage of the disease. We can have familiarity that is in some cases typical, and it is very important to recognize this. And in some cases, we can have some exception, for example, in case of CADASIL, in which we can have multifocal and asymmetric involvement. You have to sorry, this was not to be included. We have to know that we as radiologists love images, and therefore we need representations to remind us of a typical appearance. This is the case of the so-called tigroid pattern, because it resembles a sort of tiger that is typical. That is this diffuse symmetric T2 hyperintensity of the deep white matter with this linear distribution that is very typical of MLD, and that can also be present in Krebe or Alexander. So it is not only a matter of presence of signal intensity, it is also a matter of distribution in terms of pattern recognition, because we can have gradients. So the signal modification can start from the anterior region and reach the posterior, like in Alexander disease, for example, or it can start posteriorly, so from occipital region and going through all the deep white matter, reaching the frontal regions such as in XALD. I don't want to go through this slide, but it is just to make you understand that just looking at the type of involvement of the signal modification, just looking at MRI pattern, you can suggest, so recognizing the typical pattern, you can suggest one disease or another. And the diseases, like you are seeing in these slides, can be associated with the involvement of a specific localization of the brain. So the cortical spinal tract, for example, are just typical of this disease and not of these others. And again, there is a sort of specific distribution. So in some diseases you can have, I can say only, but specifically the parieto-occipital pattern, such as in Krabbe disease or an X-linked ADL, or you can have the frontal pattern or the periventricular or the subcortical or the brainstem or the cerebellar involvement. I am not saying that you won't have all these patterns together, but I am saying that if you if there is a presence of one of these, you can and you should have to keep in mind some specific diseases. More frequently, some patterns occur together, and this is the case of XLD, in which we have parieto-occipital pattern together with the frontal pattern. And for this reason, you will have also the typical clinical presentation, because you will have psychiatric presentation and disturbance in terms of memory. Remember also that you can have not only the involvement of the deep white matter at the level of the parieto-occipital pattern, parieto-occipital region and the frontal region, but you can also have in this kind of patients the involvement of the corpus callosum, but in some cases, in the so-called intermediate form, you can also have the involvement of the spinal cord, like you see here, and the involvement of the cerebellar region. There is also a matter of evolution of the disease, because as Maria, I've told you that you will not have evolution in some specific diseases, but if you have it, you can see it on MRI, and you can see it just adding contrast injection. When you see enhancement, this means that you have a progression of the disease. In case of XLD, also there can be a specific involvement of the deep white matter and gray tracts, the corticospinal tracts, like in this example, in which you have also enhancement. And you can also have the representation of a typical setting. So if you see, like in these patients, the involvement of the corticospinal tracts that is bilateral, that is associated to extensive hyperintensity, but posteriorly located, so bilateral, asymmetrical, posteriorly located involvement in the cortical tracts, you immediately think about of Krabbe disease. And in this case, you can have a specific involvement also of corpus callosum, but the extension of the involvement of the corpus callosum is dependent of the stage of the disease. So you can have also a sort of grading using MRI, and the grading means that you can help the clinician looking at MRI in defining the level of the disease. So if you have the typical, what we know that is the typical involvement of a specific region of the brain, or if you have the total involvement of the well-known specific lesions and region that can be involved by the disease itself. So, like for example, again, Krabbe disease, you can have involvement of the pre and post central gyrus, of the corona radiata, of the optic radiations, of the corticospinal tract, of the medial lemniscus, and you can have involvement of this region all together, or just one according to the different degree of the lesion at the moment in which you are facing this patient. And also, another thing that you again should consider is that you have, even if in a well-known disease such as Krabbe disease, you can have the so-called classical pattern that can be more or less pronounced, and that can be associated to a more extensive leukoencephalopathy, or you can have other presentations. So the extension of the signal modification that usually is associated to a global involvement of the deep white matter, in some cases is associated to a patchy involvement. So the white matter is the same, but the involvement is different. In the first case, the typical presentation, you have diffuse involvement. In another presentation that is not atypical, but it is not so frequent, you can have, again, an extensive pattern, but also with a patchy presentation. The same is for the frontal pattern that is, again, typical for metachromatic leukodystrophy. Remember that this extension, like in this example, is usually associated to atrophic changes. But this means that if you have atrophic changes, we are facing with a late stage of the presentation of this disease. So MRI can help you in define the typical pattern, the grading of the disease, but also to distinguish between different forms of the same disease. For example, in metachromatic leukodystrophy, you can, well, we know that there are different forms, so the late infantile, the juvenile, and the adult presentation that can differ for the extension of the diffuse hyperintensity of the white matter that is symmetric, but it is very different in these three different forms. If this is the late infantile, you have a very huge extension of the hyperintensity associated with the tigroid pattern. Instead, in the juvenile, you will have a more symmetric distribution involving the entire region of the brain associated to a thinning of the deep white matter. In the adult phase, as I have shown you before, you will have probably more frequently an involvement of the frontal region that is associated to atrophic changes. Some words about the brainstem involvement. Brainstem can be involved in these genetic diseases and can be more frequently involved in some specific diseases, such as Alexander, for example. And involvement of the brainstem means both presence of signal alteration and atrophic modification. So you can have white matter signal abnormality at the level of the medulla oblongata, and that in some cases can also extend to spinal cord that are pathognomonic of this disease. But you can also have middle cerebellar peduncle involvement that can be also associated to focal atrophic modification. In some cases, when you have brainstem involvement and or associated to spinal cord involvement, you can also have the supratentorial involvement of the deep white matter. Just look at this image. You see diffuse hyperintensity of the deep white matter, but it is very, very peculiar because it is not completely extending to the deep white matter. If you just remember this image, the image of the metachromatic leukodystrophy, the definition at the level of the report will be the same, so diffuse hyperintensity involving the deep white matter, but the extension, it is very, very different. So remember to be able to describe in your report the difference in the distribution of this signal modification, and also to include the evaluation of the cervical spine that in some cases is associated with the involvement of brainstem. Another important thing is that when we are dealing with this disease, we should always include different sequences, so T1, T2 FLAIR sequences, but also spectroscopy and also SVY. I will show you in a while how these specific sequences can be very helpful. This is again an example of a rare IR mutation. This means in this disease we have leukoencephalopathy with brainstem and spinal cord involvement. But if we apply spectroscopy at the level of the cerebellar region, we can see the presence of a peak of lactate that is, I can't say pathognomonic, but can suggest the presence of this disease. And again, in the case of CTX, that is a treatable AR lipid storage disease, what we can see that is very typical is the involvement of the cerebellar region that is again symmetric, but it involves very deeply the cerebellar region that can be associated also to the involvement of the corticospinal tracts, again in a symmetric distribution, with a symmetric distribution. But if you acquire spectroscopy, what we see, it is very, very typical, because you see high lactate and lipid peaks with a low NNA distribution that is again pathognomonic. So we have seen that we can have different involvement of different regions, but this different involvement can be distinctive features if we are able to put together all these information. Another important thing is that we should look at the presence of T2 hyperintensity, but also to the presence of homogeneous distribution of this T2 hyperintensity that can be or not associated to the presence of cysts, cavitation, or lacunes. And if we add to our protocol SY sequence, we can also look for presence or absence of calcification, microhemorrhages. If we add gadolinium injection, we can see if there is or not presence of enhancement that usually is associated to the progression of the disease. And again, adding spectroscopy can help us in not only suggest one disease, but also make differential diagnosis with other diseases that can have similar appearance. Always include in your study spinal cord, at least at the first examination. And this is just a slide to remember that if we know the disease, there are some distinctive features that can be searched in our evaluation of an MRI. But again, if we don't know the definition of the disease, just starting from the features that are coming up from MRI, we can suggest some disease with a sort of, I can say, confidence in not in the majority of the cases, but in some cases. Again, some example of this disease is a vanishing white matter disease that is a very, it is a tremendous disease in which you have a progressive disappearance of the deep white matter. At the beginning of the disease, you have a signal modification with the T2 flare intensity that is completely alterated. And as far as the disease is progressed, you will have a cavitation, cystic modification, and disappearance of the white matter that is really vanishing. And at the end of the disease, you will have the white matter that is hypointense on T2 and flare. This is another disease that is CADASIS, as I told you before. If you add the SY at your acquisition and your standard protocol, you will see presence of hemorrhages. And if you look careful, you can see also a distribution that is quite peculiar, because it is not only an involvement of the deep white matter, but it is an involvement of also of the temporal region that is pathognomonic of this disease. So just looking at the distribution of the signal modification and of the presence of hemorrhages, and in some cases also lacunae, so small vessel infarcts, and presence of extensive infarcts, you can suggest the presence of CADASIS. So again, it's very important to look at the presence of hemorrhages, but also at the presence of calcification. Calcification is something that is present in this genetic disease, and it is present in two different ways. One is just the presence of the calcification. The other is the presence of the calcification in specific region. So This is again a panel quite complex. I have magnified here some examples, but it is just to tell you that if you have calcification, and for the correct evaluation of the presence of the calcification, you can use SY sequences on MRI, but it is better if you add the CT scan to the evaluation of your patient. If you have a calcification that are symmetrical and deeply located, you can also have an involvement of cerebellar region. You can again think about of specific disease. SY together with CT can help you in defining the presence of this calcification, the distribution of this calcification that in some cases, like in this example of leukoencephalopathy with axonal spheroid and pigmented glia, you in this example you will have the typical dislocation of this calcification that are very closely related to the ventricular region, and in some specific moment of this disease, you can also have the diffuse signal modification that is represented by T2 and flare hyperintensity, associated also with reduction on DVY. DVY again is something that you should add to your protocol. So again, T2, flare, T1, SY, and gadolinium injection can help in the evaluation, in the suggestion of presence of this specific genetic disease, and also can help you in defining the modification of the deep white matter. In some cases, like in this example of leukoencephalopathy, that is generally defined as leukoencephalopathy with calcification and cyst, that is a representation of a genetic microangiopathy that is due to a mutation in a small nuclear RNA of a specific gene. You will have not only a diffuse T2 hyperintensity, but also presence of cystic lesion. And in some cases, the cystic lesion are very huge and can determine also mass effect. But if you have these cysts very huge associated to microhemorrhages, calcification, and deep white matter signal modification, we are not looking at a classical vascular disease. We are looking at something different. And again, when you see presence of diffuse hyperintensity of deep white matter with calcification that are not typical, that are not peculiar, especially that are not strictly related to the age of your patient, please consider always to include a systemic evaluation of this patient, like in this case of polycystic lipomembranous or osteodysplasia with sclerosing leukoencephalopathy, the so-called naso-acola disease. Just adding an X-ray of the hand, you can suspect a more extensive diffusion of this disease. Some other example just to make you understand the importance of approaching MRI with an extensive protocol. This was an example of retinal vasculopathy of a patient with retinal vasculopathy, cerebral leukoencephalopathy, and systemic involvement. If you just look at this patient, you see the presence of multifocal punctate white matter lesions with some kind of enhancement, and with distribution of the signal modification that can resemble the Dawson fingers. So you can suspect multiple sclerosis. But if you if you just look at these images, just adding a CT scan, you won't have calcification in multiple sclerosis, especially calcification associated to signal intensity modification associated to focal atrophic modification. This means that you have to put together all this information. This is again just an example, and I'm quite reaching the end of my presentation. This is a patient with a COL4A1 related disorder in which you have diffuse T2 hyperintensity. If you just look at the flare, you can think about a vascular disease, a standard vascular disease. If you just add gradient echo or SOI, you see that there are hemorrhage, but also microcystic modification if you acquire CT scan. So something that can be, well, not in all the patients we do CT scan. Usually we start with MRI, but if you just add the CT scan, you will see a diffuse and extensive hypodensity of the deep white matter that won't be present in a classical vascular setting. And also you can pick up the presence of these brain calcification that are typical of this disease, that are frequent as they are represented as puntate and typically located in the basal ganglia. Again, in case of cerebral amyloid angiopathy, the same thing that I was telling you before, the diffuse hyperintensity is associated with extensive hemorrhage that can be focal or diffuse. Usually the distribution is bilateral, but it is not symmetric as we have seen in the other group. And we can also have some predominance in the distribution of the signal modification that typically is posterior, even if we can also have frontal involvement. But just to give you some clues, when you see diffuse symmetric distribution of signal modification that involve cerebellar region, but also cerebellar peduncle, include always spinal cord evaluation. And if you see also presence of atrophic modification, include SY to see if there are or not calcification. And just put together all these things, and you will be able to make, first of all, differential diagnosis with inflammatory disorders. But secondary, you can consider also specific leukodystrophies. Just to conclude my presentation, I have to say that even if in this genetic disease, that in which we know that there is a deep involvement of the white matter, we can have, even if in this disease, presence of inflammatory components, and we can have the so-called inflammatory pattern. And when we have this inflammatory pattern, we should be able to make differential diagnosis with MS. Again, looking at the typical or atypical features and just thinking about of this possibility. Because if we are looking to a patient of 40 years old with a diffuse hyperintensity, symmetric, but also with focal distribution, with a sort of dozen finger, the first thing that we are thinking about is MS. But if you look more deeply in the diffuse distribution of this T2 hyperintensity, you can or you should consider also presence of other diseases such as this genetic disease. So in conclusion, in our imaging workflow, it's very important to keep in mind the pattern recognition. So the distribution of the deep white matter signal modification, symmetric anterior, posterior, the degree of the extension, the association to atrophic modification, the involvement of the cerebellar region, the involvement of the spinal cord region, the presence or the presence and distribution of calcification can help you in making the differential diagnosis, but also to define or suggest genetic disease. I conclude with this slide. In the future, but future I think is now, we can have an help that is coming from machine learning and multiparametric software that can add all the information that usually we are looking at together. We can put together on this information and send you a sort of suggestion, a specific suggestion that can be able to help you at least in make differential diagnosis in general, but specifically with multiple sclerosis. So I have concluded, and I share again the floor with Maria. Thank you.
Okay, welcome back. So now we have our patient. We have this huge amount of information from the neuroradiologist. Our following step would be to exclude the more common causes of white matter disease, even if, of course, as Simonetta said, we have really a huge amount of information from MR, which can just help us in differentiating between acquired and hereditary. Of course, the more common are small vessel disease. Therefore, we have to go through all the vascular risk factors, age, smoke, hypertension, and so on, or inflammatory small vessel diseases. So to look for acute phase reactants, autoimmunity screening, if it is required, or we can discuss with the neuroradiology the opportunity of an angiography, look for systemic symptoms, and so on. CSF analysis, more than giving us a specific information on the genetic white matters, it is very useful, of course, for differential diagnosis. Oligoclonal bands are absent in genetic disorders. The chemical-physical exam is really aspecific. We can observe a slight increase in protein contact in demyelinating variants and a slight increase in cellularity in Aicardi Gutierrez. The only specific test we can perform on CSF is the dosage of N-acetyl aspartate, which is elevated in Canavan disease. What can be really relevant and very useful that can really help us in the diagnosis of some genetic disorders is to look for the involvement of other organs, which can be quite typical in some of them. In particular, one of the more frequent involved system is the ocular system. You can observe optic atrophy, especially in the advanced stages of the disease in MLD, GLD, ILD, and so on. Typical cataract in CTX. Nystagmus is very typical of Pelizaeus-Merzbacher, which is a early onset anyhow disorder. You don't have a late and adult variant of Pelizaeus-Merzbacher, cortical blindness, and so on. It could be very useful to have a dermatologic evaluation. Of course, you look for xanthoma, the presence of xanthoma in, again, in CTX, the presence of melanodermia in the adrenomyeloneuropathic phenotype of EXLD, the presence of visceral signs, again, typical gallbladder dysfunction in MLD when you have an accumulation of sulfatide in the wall of the gallbladder, or the presence of a chronic diarrhea, again in CTX, and so on, endocrine dysfunction with premature ovarian failure and adrenal insufficiency, and again, so on. We have said about the involvement of peripheral nervous system, so it can be really very useful to perform an ENG and EMG. And another typical pattern is palatal myoclonus in Alexander disease. Look for dysmorphism and look for dental abnormalities with the typical of oculodental digital dysplasia, a syndrome which is very, very rare, but that can have an adult onset. Okay, if we have time, we can share some clinical vignettes. We go? C'è che non abbiamo il microfono?
Yes.
Okay,
Yes.
you can hear us?
Yes. Okay.
Okay.
Yes.
We were afraid to be abandoned. To have spoken for more than an hour, just the two of us. Okay, so we have just a few clinical vignettes and then a few slides on therapy. But this, okay. We show the surprise because we don't have the full screen presentation. Okay, so this is 31-year-old female. She presented with personality changes and cognitive decline, slowly progressive over the last 2 years. Of course, she performed a brain MR, and what we observe.
Starting from the top, so from the central semiovalia, we can see a diffuse, symmetric, predominantly anterior hyperintensity involving the frontal region, but going down involving the periventricular region, and associated, you consider the patient is 31 years old, associated to enlargement of the sulci, so with an atrophic presentation. Again, if this is the first examination, the bilateral diffuse signal modification should make you think about something that is not acquired, but that can be congenital at least.
Okay, the other pattern, which is, and we will see on another, the following case, as we have said before, and as Simonetta said before, you observe a sparing of the perirolandic region that, on the contrary, you will know to be particularly involved in another demyelinating leukodystrophy. Anyhow, the patient, she performed also an EMG and with demyelination polyneuropathy, and she was positive for she had a very low level of sulfatase A, and we concluded for a adult onset metachromatic leukoencephalopathy. What I want just to remember is that the diagnosis of MLD can be a misdiagnosis, because there is this condition which we call pseudodeficiency, which is associated with 2 cis mutation in the ARSA gene. And this condition with these 2 cis mutation lead to a very reduced level of ARSA, which has around 15%. We have a residual activity of more or less 50% compared to the normal ARSA level. And this, the presence of this pseudodeficient allele has a very high frequency in the normal population, reaching 50%. So the presence of low levels is not associated with a progressive disease. You can observe sometimes very slight alteration at brain MR, but no clinical symptoms and no progression. The way to distinguish between a carrier of a pseudodeficiency and MLD is looking at sulfatide excretion in the urine, which is increased in the real MLD patient and is almost normal or just slightly elevated in the pseudodeficient patient. This is another patient presenting with personality changes and cognitive decline with a slowly progressive course. Of course, he performed a brain MR.
And again, what it is quite typical is the presence of, again, 39 years old. So there is atrophic modification that is diffuse. There is a thinning of the corpus callosum. And what you see also just in this slide, it is obviously not easy to express, but there is a thinning also of the deep white matter. On CT scan, that, as I told you, it is helpful, especially at the level of the diagnosis of these patients. You see, again, atrophic modification in the frontal and in the temporal region, but also presence of this smooth hyperdensity at least in the lenticular region, but in the deep basal ganglia, that is an expression of a smooth presence of calcification. So not a focal calcification, but a diffuse extensive calcification at the level of the lenticular region bilaterally and quite symmetrical.
The diagnosis was a nasoarcola disease. The what was not common in this patient was the absence of bone involvement. So as we said, we have to look for what we consider typical, but the absence of the typical features should not allow us to exclude this rare disease. So we have, I guess, some cases with spastic gait presentation. Let's go on. This is a female, a young female, 25-year-old. She presented with an asymmetric spastic gait that was followed by cognitive decline. Anyhow, the presentation was with a rapidly progressive spastic gait, no familiarity, but the presence of ovarian failure, which is a characteristic very suggestive of.
And again, what is typical and classic is the involvement of the corticospinal tract. And remember, the symmetricity is something that is to be focused on, and the association of the atrophic modification that is prevalent on the posterior region. And there is also a focal involvement of the corpus callosum with the myelination that is not completely expressed in this slide, but it is appreciable on the T1 as focal hypointensity, a deep and a strong hypointensity on T1. And again, these two features, so the myelination and the involvement of the corticospinal tracts associated to atrophic modification, can suggest something that is not acquired, but it is present as a genetic modification. I can say that just looking at these two images, I can say, oh, yes, it is clear it is a microgliopathy. But what you have to think about is that it is not typical of any other disease, such as genetic disease. So just go through of the typical presentation of lesions that involve specifically corticospinal tracts associated to atrophic modification.
Okay, very specific system involvement and very symmetric. Next one. Again, a 46-year-old male, spastic gait, spastic ataxic gait as presentation followed by cognitive impairment. He performed brain MR.
And again, what you see is an involvement of typically the deep white matter, symmetrically involved with a sort of, it is not a tigroid patterns typically, but there are microcavitations inside. So there are areas of more focal rarefaction into the deep white matter. There is a thinning of the corpus callosum, so there is a sort of degeneration because there is a thinning of this structure, and you can have some extension of the deep white matter modification also in the temporal, in the white matter that is related to the temporal region, but also in the cerebellar region. All these presentation is again symmetrical, bilateral, and diffuse in the same way between one side to the other.
And again, the good eye of the neuroradiology, who can distinguish between cavitation, which are more typical of vanishing white matter disease, and tigroid pattern, which is much more typical of, that is, as Simonetta said, as a kind of strie we see in the white matter, which is much more typical, for example, of metachromatic leukodystrophy. This is a very interesting case from a radiological point of view, spastic ataxic gait and a bilateral foot drop, therefore central and peripheral involvement, which was confirmed at ENG, and the very typical radiologic presentation.
This is what I was saying before. So you have an involvement of the deep white matter that is symmetric and extensive, associated to an atrophic modification. So we have these sulci that are very deep, especially in the posterior region. But the involvement is also of the cerebellum and spinal cord. Spinal cord is involved typically in the posterior region. And this is an involvement that is frequent, not only in the presentation of the genetical diseases, but the typical thing is that the involvement of the posterior region is associated with the involvement of the lateral columns also, and also of the pyramid region. So both cerebellar, truncus, bulbar, yes, anterior parts of the bulb and the spinal cord. You can also have an involvement of the point of the passage between the pons and the cerebellar region, which is the place of the localization of the trigeminal nerve pathway. That again is something that is specific, quite specific of this disease.
Okay, next one, as we have said before, a woman with a slowly progressive spastic gait, whose onset actually was around 38. She performed brain MR, and as we have said before, look at the specific pattern.
The thing again is what is involved? Is involved the corticospinal tracts? Yes, it is a symmetric involvement. You have a localization at the level of the central sulcus. It is also involved the splenium of the corpus callosum. You have also an extension to the cerebral white matter posteriorly involved, associated with focal atrophic changes. And also you have also a passage at the level of the corpus callosum into with an involvement of the motor fibers. Again, what I have to say, I can't say this is this disease. What I can say is the spinal cortical tracts are involved, associated with atrophic modification. The modification of the white matter disease involve predominantly the posterior region, and there is also the myelination of the callosal region. So this information put together can suggest specific diseases. There is a sort of toolboxes, as I have shown you before. You have to go to look at these boxes. What is inside can suggest the presence of Krabbe disease.
Maybe we can go a little bit further because we are running late. So this again a 49-year-old female, and she presented with ataxia and bulbar signs. She performed a brain MR.
Again, you have, in this case, specifically the involvement of the medullary region. So you have medullary and spinal cord atrophic modification. The signal modification is present, but it is not the primary information. The primary information is the atrophic modification. Again, remember that in all these diseases, there is a gradient of involvement, and usually the posterior regions are involved more frequently at the beginning of the disease. What I have to say is that this specific image, so the involvement of the medullary region is or can be associated also to focal T2 hyperintensity with this typical image that once you have seen it, once you should recognize it, and you can think about Alexander disease.
You don't forget it anymore, more or less.
No.
Last two cases, just to make the picture a little bit more complex. This was a patient I had the opportunity to see once when I was in Cremona. Actually, she had a very long story dating back. I put an onset in 2009, but actually she complained transient focal weakness at lower limbs. Anyhow, she dates the onset more or less in 2009 with hyposthenia at the right lower limb. She performed a CSF, which was negative, oligoglonal band absent, but a diagnosis of MS was was done based on the first MR she performed in 2009. I've done something that. Okay, then she did a follow-up images in 2010, and she came to our attention in Cremona in 2017. I leave the comment to the MRI to Simonetta.
So this is just a practical case. So when you just look at the first images of MRI of 2009, what you can see is that there are some bright spots in the subcortical region and the periventricular region, bilateral but not symmetric, and are in the, I can say, typical localization of inflammatory disease, but inflammatory disease and some other things. But it is something that can, well, it is not difficult to think about MS in this first MR acquisition. The second MRI is quite stable, except for a new lesion here that is deeply located in the lenticular region, and maybe
a small enhancement. Maybe.
Yes, with some small enhancement that can be associated, but the modification, the more extensive modification is between 2010 and 2017. You see more and more other lesions that again are periventricular, that are deeply located, but also in cortical, subcortical region, that are discrete regions, so that there is not an extensive modification of the white matter, but there are multiple lesions that involve supratentorial white matter, but even the pons. And in the second control, that again is in 2022, you have an extension and an increasing in the amount of lesion that are, yes, bilateral, but that are not symmetric and involve all the white matter, both anterior and posterior, and that involve also the inferior, the cerebellar parts with, I think this is a true enhancement, I guess. And this patient that be treated for MS, but without really a true response, both clinically and radiologically.
She had a very poor adherence therapy, so she self-suspended all the drugs she was proposed. In 2017, we were not really convinced on the diagnosis. We referred the patient to a colleague at Vesta Institute in Milano for some genetic analysis, and actually she was diagnosed as Alexander disease. So remember that it's not always easy to go through. Last case, she's a patient who performed this brain MR for a neurosensory deafness, and she's almost asymptomatic. I had the opportunity to see her just a few months ago after 2019. We have been following her for 3 years. She remained more or less asymptomatic, and she performed all this MRI. Actually, this is just one. We have not all the follow-up because we are running short of time. Anyhow, she is without a diagnosis.
This is just the last case to leave you with the suspense, because we still don't know the diagnosis of these patients. But what I can say is that there are some of the typical features in this MRI that I propose to you in all this lecture. So there is a diffuse hyperintensity of the deep white matter. It is bilateral. It is not symmetric, because it is slightly asymmetric with an involvement of the left hemisphere that is predominant. There is cortical-subcortical region involvement, that is periventricular region involvement. You have some dot spots on SY, and you have not presence of enhancement. So, but there is also the involvement of the cerebellar region, because the left middle cerebellar peduncle is involved. So we have some suggestion, but not all the features are respected. So at first we thought about inflammatory disease. Now we are moving to genetic disease. But
we have discussed again with our colleagues at Besta, but she doesn't have a typical pattern of among the one you have seen with Simonetta, so we are not oriented toward any specific disease actually. Just the last 3 minutes, I really go very fast on these slides. Regarding management strategies, of course, for this disease, we can offer the patient just supportive therapy or in some cases, disease-specific care. It has been proposed in the past allogeneic hematopoietic stem cell transplantation based on the concept that stem cell can provide the deficient enzyme in diseases such as GLD or MLD, but with very modest clinical benefit. In some cases, it has been proposed enzyme replacement therapy. The real problem with the ERT is that the enzyme doesn't cross the blood-brain barrier. So again, the benefits are really, really modest. There are some trials ongoing with the intrathecal administration of the enzyme. And last, gene therapy. Gene therapy, there are some trials ongoing up to now. And there is one gene therapy strategy approved for just MLD. And I want to end up with these 2 slides. The rationale of hematopoietic stem cell gene therapy relies on the fact that some viral vectors, such as adeno-associated viral vectors or lentiviral vector, can be engineered and can be transduced or can be modified, including the defective enzyme. Then cells can be transduced with this construct containing the defective enzyme. So what we have, this is a long story which started more or less at the beginning of the century, and it was a full Italian story. And I had the honor, I would say, to be the co-PI of the study, and Simonetta with her colleagues, Cristina Baldoli, they participate to this study because they contribute with the definition of one of the major endpoints, which was the magnetic resonance. And the strategy consisted on the harvesting of stem cells from the patient, the transduction of the stem cells with the lentiviral vector, and the reinfusion in the patient, which was fully myeloablated with a busulfan conditioning. And the rationale is that the genetic modified cells can overexpress the enzyme. They cross the blood-brain barrier, they colonize the CNS, they overexpress the enzyme. The enzyme is secreted in the extracellular space and is uptaken by the defective cells through a receptor-mediated uptaken. And we can show the the animation of the slide, but the results were really striking. We published the first result in 2013, and then in 2016, 8 patients in the late infantile variant and 1 in the early juvenile. And I just leave the comment to Simonetta of the Brain MR. This is the patient treated 24 months after treatment at the age of 40 months. And this was the sibling who unfortunately could have been treated because it came to us who was already fully symptomatic. And look at the striking difference of the 2 patients.
Well, I just want to be sure that you appreciate on the right side of the slide the patient that have been treated, and on the left the one that has not been treated. But what you see, since they are siblings, is that on the left, so on the patient that was not treated, you have a diffuse extensive signal modification of the white matter that is completely substituted, that is completely alterated, and also there is an atrophic modification that is very extensive. The extension of the signal modification include also the pons, and also either the atrophic modification are in the cerebellar region. And on the right side, you have a completely normal signal of the white matter and a normal trophic presentation of the brain. So the patient on the right is completely normal according to the presence or absence of signal modification.
This was our long story. The strategy was approved for marketing authorization at the end of 2020 after more than 20 years of very long work. Unfortunately, this strategy, up to now, there are some other clinical trials ongoing, are restricted for late infantile variant. But what is relevant is this is first in human strategy anyhow, so we hope that in the future this can be available also for other diseases, leukodystrophies, maybe for other type or onset. And what is relevant that the presence, the availability of this strategy make possible to perform prenatal diagnosis, and so to intercept the patient before they become symptomatic. We just end up with a few slides for the audience with some bibliography, and we want to thank you for your attention. We took the opportunity to, if any one of you is interested, Bergamo will be the how you say the place of the 2 national meetings, the meetings of the Italian Society of Clinical Neurophysiology and of the
Italian Association of Neuroradiology. One is very close, is at the end of next week, and the other is in October. So if you have the possibility, we all invite you, and
it was a pleasure to have you.
Thank you very much for being here for this opportunity. Thank you for attention.
Is there anybody on the other side of the screen?
Okay, I think we have a question. Meral? No?
Yes?
I don't have a question, but I really thank for this presentation, because we have Starlink with crowded outpatient clinics, and we have no time to make a good differential diagnosis. So the MRI is helpful to make first differential diagnosis, as you show, symmetrical and some other chains. And but some tests are not available for our clinics also. This is the main problem, I think, for our clinics. Thank you for your presentation.
Thank you.
Thank you.
Okay, guys. I don't know if anyone else has a comment or a question, but if not, I'm sorry to be this quick, but we have already Professor Alusi here. So,
Okay,
yeah.
anyhow,
Hello. Yes, hi. Can you hear
can
me?
share our slides with all the audience, and if they have any following questions, we will be very pleased to answer even by emails.
Thank you very much.
Can we make
Thank you for your time and patience.
Excuse me. Can we, if we have some difficulty in differential diagnosis, can we send you the cases to?
Sure.
Of course.
Okay.
Sure.
Thank you.
Be a
Thank
pleasure.
you.
You're very welcome. Thank you.
Thank you.
Bye.
Sorry for being running late.
It's okay. Don't worry. Have a nice evening.
You too.
Thank you. Okay, Professor Alusi, you can go on when they stop sharing. You can share your screen.
Can you hear me, Mary?
Yes, I can hear you.
Yes, you can hear me. That's good. Yes, I'll start sharing the slides. Bear with me. By the way, I'm Dr. Alusi, not Professor, but yeah, thank you for promoting. It's okay. So I'm a clinician, not an academic, but I've done a lot of research in MS tremor. So I guess that's why the organizers have asked me to give this talk. Thank you very much for asking me. Let me just see if this will share properly. Bear with me.
Yeah, I think Professor
yeah,
or Dr. Gerevini is still sharing.
Want me to? Yeah, I'm just gonna share. Just one. Is it sharing?
No.
No. Yeah. Okay. Try again. So share. Here we are. Let me just get the correct one. I'm sorry. Just give me a second.
It's okay. Don't worry.
Yeah. Whilst I'm doing this, if you're going to record, there are videos of patients that I don't particularly want to record, please. I'm just wondering how we're going to go around that. Is this
okay. Normally we record.
Yeah, and then you could delete, or how do you do it?
We record the whole session. The thing is, like, I can't just stop it for a while and then keep going on. Normally in Zoom you can do it, but here you can't. I don't think so.
Okay, so just see if this is sharing yet. I've shared it.
No.
No?
No.
Yeah, I could just give it a second. Why is that sharing? So it's sharing on mine. I'm very sorry. Let me just double check why I'm doing screen. Okay. Okay.
Okay, yeah, we can see your screen now.
You can see my screen. Now I'll put the talk so that you can see the talk, which is the main thing. You don't want to see my screen. Okay, so let's go for slideshow. Here we are. So from the beginning. Can you see this? Yes?
No.
No, we can't see it.
It says it's sharing. Let me just see again. I'm sorry. It's showing on mine. And show. Okay. Can you see the screen? Can you see my mouse? Yeah?
No, we can't.
You can't see it. So stop sharing. Right. Let's go back then. I'll just stop sharing and do it again. It is.
Maybe you can put your presentation first and then start sharing.
Yeah, no problem. I thought I did that, but no worries. I'll do that again. I'm sorry. Just give me 2 minutes. So this is on my screen now. And then if I say share, which I did, let's share this. Right. Yeah?
Yes, now we can see.
Yes.
Oh, thank goodness I can breathe now. Okay. Okay, here we are. So do you want me to start?
Yes.
Yeah, okay.
Normally, if anyone has questions, I will say they can interrupt, but it's up to you. And at the end, I can also help you manage the questions.
Yes, of course. I mean, you can ask whenever you like, guys. I'm very open. I think I've got less than 1.5 hours, so that you can interrupt as much as you like. I appreciate it's a tricky subject. I can't see your hands now unless I reduce this. So let me just see if I could reduce, or maybe, I mean, if you could shout out if there's a question, that would be good, if that's okay with you. Yeah? Because I'm not seeing your hands now. Yeah?
Yeah.
Would that be okay?
Yes.
Hello? Yeah?
Hello. Yes.
Yeah, that's okay. Okay. Right. So my name is Sundus Alusi. I'm a neurologist from the Walton Centre in Liverpool, UK. I'm really grateful for this opportunity, actually, because this is my research work many years ago. But I'm very proud to try and present it, but also really teach about coordination and tremor in multiple sclerosis. So I gather this is from your second module. So I thought that I'd start with basics, because although I know you're all esteemed probably neurologists, but I thought I'd start with basics and then we go a bit harder. And by all means, you can interrupt me, but please shout because I can't see the hands anymore. So ataxia is a term which you probably all know, Greek, which impairs, which really is defined as impaired coordination of voluntary muscle movements. So it's a sign rather than a disease, and depending on which condition you're going to get ataxia in, it's either isolated ataxia or combined with other deficits. And of course, in multiple sclerosis, it's usually combined with other deficits. And it's caused by dysfunction of the cerebellum at the back of the brain itself, or its connections, which we'll show a slide on. So you've all seen this many times. This is, by the way, I've sort of copied it from this, so I just shared it with you. Copyright. This is the cerebellum, as you know, and that is the superior cerebellar peduncle that goes to the midbrain and then onto the cortex.
Excuse me.
Alusi, I'm sorry, we can't see your slides.
What's happened? Have they stopped?
Yep.
Maybe if you pass them, like just with the buttons doesn't work. It happened with the professors before, so maybe you just have to click on the slides beside.
Click on the slide. Okay, so like this is not moving into.
This is not moving.
Okay, let me see. So you want me to just go to next like that?
No,
does that show?
We can't. Do you have presentation mode?
Yes.
We can't see it in presentation mode, so you can go off the presentation mode and then just click on the slides in order to.
So you want like this?
Yeah.
So this is better like this?
Yeah.
Okay, it's fine. Let's go to that. So slideshow doesn't work. Okay. So sorry. The definition is it's impaired coordination of voluntary muscle movements, and it's a sign rather than a disease. And then I was just showing you the cerebellum here. Can you see that? Yeah. Can you see?
Yes, perfect.
Yeah. So the superior cerebellar peduncle connects the cerebellum with the midbrain, and from there onto the cortex. The middle cerebellar peduncle is this one, which connects the cerebellum to the pons, and this is very important when it comes to tremor. And the inferior cerebellar peduncle is the one that connects you with the corticospinal tracts and also the sensory input into the cerebellum, which is very important with ataxia and tremor. And as I said before, ataxia can be due to many conditions. And of course, here you're interested in MS, but of course, I'm sure as clinicians, you would want differential diagnosis. So when you see a patient with ataxia, you want to make sure it's not, if you don't know the diagnosis of MS and you're just presented with a patient with ataxia, you want to investigate for the differential diagnosis. So ataxia can be hereditary due to many genetic conditions or acquired, for example, multiple sclerosis. And we always try and look for the treatable causes of ataxia, for example, hypothyroidism, B12 deficiency, B1 deficiency, and all this. So acutely, of course, as you know, in neurology and in medicine in general, we could only diagnose from the patient's presentation in terms of chronological events. So if the ataxia became acute, came on acutely, you are thinking of vascular causes, particularly such as cerebellar infarction, a stroke, cerebellar hemorrhage, or infection. Multiple sclerosis is also actually considered acute in that it can take days to develop that. That's not the updated slide, sorry, it should have MS in the acute as well. And subacute belongs to autoimmune or inflammatory conditions. And this is things like paraneoplastic conditions or celiac disease, for example. Some infections can give you subacute over weeks to months, such as HIV or syphilis. And then if the patient presents with very chronic condition or very chronic ataxia, you are then thinking, is this hereditary? You know, if the patient has had ataxia since the age of 12, for example, you're going to look at things like Friedreich's ataxia, spinocerebellar ataxia, and things like that. It can be neurodegenerative. For example, Fragile X-associated tremor and ataxia syndrome, whereby the patient is well until they become 50 or 60, and then the ataxia signs start to show. That's a neurodegenerative condition. And then chronic infections, again, like syphilis, and some tumors, for example, a meningioma can present very slowly with a chronic ataxia. So in multiple sclerosis, the ataxia can happen, as we said, acutely because of demyelinating plaque in the cerebellum or in its connections. And it can be present, you know, contrary to tremor, ataxia itself can actually be during an acute relapse. We'll come to tremor in a minute, but tremor is more of a chronic progressive. It comes on progressive disease. So ataxia can occur in a relapse and can also occur in the progressive phase. In an acute cerebellar dysfunction, in multiple sclerosis, sorry, that is present in 10% of the presentations. So the ataxia is always looked at as a poor prognosis or one of the worst prognoses in multiple sclerosis. And I'm sure you're all aware of the Weinschenker studies in the 90s that showed, you know, if you present with ataxia from the beginning, you're going to have worse prognosis as the disease goes on. It also is one of the things in multiple sclerosis that you're at risk of. If you have multiple sclerosis, then up to 80% of patients will encounter ataxia towards the end. So it's more common though in the progressive phase. So although I said it can come on in a relapse, it's a lot more common in the progressive phase because of the neurodegenerative component of multiple sclerosis. So in the acute inflammation, you can see it, but you can also see it as things start to degenerate. Tremor, on the other hand, will occur mainly in the progressive phase. Now, because this is a master's course, the Charcot master's course, I can't really avoid mentioning this, and quite appropriately, really, because Charcot is the first person who described the triad of nystagmus, intention tremor, and scanning speech. So in other words, ataxia, as characteristic of multiple sclerosis. So if you see a patient with all these three, you need to think MS quite high on your list. Thought we should mention him, shouldn't we? Right, and whilst we're on Charcot, I thought I'd tell you about this. I found this whilst I was preparing your lecture. There is a blogger called Mona Sen, who talks about how Charcot's triad has affected her. And although I'm not going to talk about it, if you're bored one night and you want to look at how Charcot's triad has affected this person, please look it up. She talks about how nystagmus affects her when she's working on her computer. She has to wait for her eyes to settle before she starts. And she talks about her speech is not so bad, but also talks about ataxia of the gait. So please look it up if you have time. I thought it was very eloquent. But then she is a health writer. So why does ataxia even happen? So the pathophysiology is very difficult. It really depends on whether you've got the ataxia acutely, in which case it's a demyelination in the white matter, and that's why ataxia presents. But at the same time, if it's in the progressive phase, it's a completely different pathophysiology. It is really difficult, and nobody quite understands why it happens. And you can get it from multiple sides. So you can injure the pons and get hemiataxia. You can injure the cerebellum and get ataxia. But I thought I'd just simplify things here. And by the way, all the references are there at the end of the talk. Just to tell you that midline lesions, if you get a midline lesion in the cerebellum, you would get gait and trunk ataxia, whilst the paravermian lesions tend to give the dysarthria. The posterior cerebellum is known to cause the nystagmus and vertigo, and limb ataxia will be more the peripheral hemisphere of the cerebellum. So how do we examine patients with ataxia? I mean, of course, in multiple sclerosis, if you knew the patient has multiple sclerosis, then it's easy. But if you didn't know, you need to look really for the ataxic sign. The patient would present with incoordinated movement, uncoordinated movement, incoordination in gait, or dropping things, or not reaching an object without smashing it. You know, and those sort of complaints the patients would give you. And of course, with nystagmus, you can get oscillopsia. So you're going to examine and looking at the signs. You start really with you can hear the speech when the patient talks to you in clinic. Then you have the so-called scanning or staccato dysarthria. When you look in the eyes, you're going to find gaze-evoked nystagmus. And as you examine the limbs, which I'll go into in a lot more detail, you will get dysmetria, which is basically when you reach a target, you miss it. When you're trying to reach a target, sorry, there's a distance between the tip of the finger and the target. And that's dysmetria, so abnormal judgment of the distance. This diadochokinesia, as you I'm sure know, is a problem with alternate hand movements. Now that could be a sign of other things, in the sense that if a person has Parkinson's and they're slow, they're not going to be able to do it. But we're not talking about slowness, but rather irregular hand movements, alternate hand movements. And this would be this diadochokinesia, which is very common in multiple sclerosis. Intention tremor is different from dysmetria in the sense that the patient would be either shaking on posture, which again I'll show in the video, or only shaking as they reach the target. So if you like, the rhythmical activity of the tremor would only appear as they reach the target, and that's called intention tremor. So intending to reach a goal-directed movement tremor. When you stand the patient, the stance can be abnormal. The patient could be having titubation, or standing with wide feet, or just unstable and unable to stand. In a normal person, you'd expect people to stand at 12 centimeters without any problem. But if the person is ataxic, then they would have to put their feet slightly apart. And before you test any of these, you have to make sure that the person is not weak. So it's not that they're standing and wobbling when they stand because they're severely weak in their legs. You need to test the power first. And if the power is normal, then we could comment on ataxia. Similarly, with heel-shin test, if the patient is weak in the leg, you're not going to be able to test heel-shin accurately. So we're talking about all these signs being present if the power is normal, provided the power is normal. And again, with the walking, if the legs are normal, more or less, sort of 4+ or 3+, even 3+ can hold the person stand, they should not have a wide base gait if they're just weak. So that's again a sign of ataxia. So I'd like to show you some video on examining ataxia. This patient does not have multiple sclerosis, but on purpose I wanted to show this to show you that ataxia can be very subtle. So I'm hoping that this will project. I'll start it. Oh, it's gone. Is it horizontal on your screen as well?
Yes, it is horizontal.
Oh my word, never mind. I am really sorry. I've tested it so many times, this didn't happen. Right, never mind. You can still see. I'm really sorry. You're going to have to turn your head. So this is me examining the patient, and you can see that the arms, when they're outstretched, are completely normal and not shaky. And in the second position, with the arms flexed, which is often what you do when you test for tremor, the person still doesn't have any arms. But as she approaches a target, can you see that when she goes between her nose and the tendon hammer tip, you see that terminal tremor? I'm really sorry about the horizontal appearance. Do you see how she's shaking towards the end? And that's called intention tremor. And you can see this patient is, even though she does not have a tremor with posture, as she reaches a target, she shakes. And that's as true as it gets for intention tremor. A lot of people call everything intention tremor, which is not really accurate. So the amplitude of tremor gets worse as she goes to target. Now you see her normal gait, well, it's not quite normal, but nearly normal and relatively narrow based. You want to tease it out and get her to walk heel toe. And as she walks heel toe, she's completely unable to do tandem gait. So again, this is a subtle ataxia of gait. So if you see the patient walking normal, that does not exclude ataxia. You need to walk them heel toe and see if they struggle. So that's examining for gait and intention tremor. We'll come to tremor in a minute, normal MS tremor. So ataxia is severely disabling.
What was her diagnosis? I'm sorry.
She has fragile X-associated tremor and ataxia syndrome, the FAXTAS.
Oh yeah, thank you.
Yeah. So if you look at her age, actually, there's a good question that, because I mean, I don't know if you're going to be tested in this master's course, but if you look at her age, if you presented with somebody this age, she's clearly over 60, isn't she? She's 60 odd. And that doesn't mean MS doesn't happen in the 65-year-olds, but it's much, much less likely, isn't it? And you look at her, she's older, and yet she's ataxic and she has an intention tremor. The first thing that, and she has an abnormal scan, the first thing that comes to your mind should not be multiple sclerosis. And I'm on purpose actually showing her to show you the subtle signs of ataxia, because in MS, the ataxia is often a lot more florid than this. And I'll show another video in a minute. But yeah, she has FAXTAS, Fragile X-associated tremor and ataxia syndrome. She's kindly agreed for me to show this video, but hopefully it would be deleted at the end. Okay, so ataxia is a very disabling condition. As I said, sorry, it's not a condition, a very disabling problem for patients. And in this really nice paper, they looked at the, I just wanted to highlight really the burden of ataxia in multiple sclerosis. And this is a study that was published in Lancet Neurology, looking at the ataxia disability weight, if you like. I mean, it's a fancy calculation how they got this, but just if you look here, and the asymptomatic is asymptomatic, and the mild, they've got numbness, slight unsteadiness, and loss of vision. As soon as you get to moderate, you have incoordination. Arm coordination becomes a problem. What I'm trying to say is that if coordination comes in and ataxia comes in, you immediately jump in the disability to moderate and severe. And that shows in the Kurtzky scale as well, which I'm going to go to. So ataxia is very disabling. It's one of these MS problems that are significantly disabling and really needs to be recognized when it's there to try and help patients with management. If we go to tremor now, sorry, do you want to ask about ataxia? Because tremor has got a lot more. Anybody wants to ask me more about ataxia before I talk about management? No, okay. So if we go to tremor now, I mean, we said ataxia is incoordination. Tremor is a completely different thing. Although tremor is present in some ataxic conditions, and indeed in multiple sclerosis ataxia, tremor is one of the main features. Tremor itself can be isolated in MS and doesn't have to be associated with ataxia. And as a definition, which is very important when you see people with lots of movement disorders in your career, is to define tremor, or to try and understand that tremor is a rhythmical oscillation. So this is defined as an involuntary rhythmical oscillation of a body part. It's very important to look at that rhythmical oscillation, because in MS in particular, you're going to see clonus because of severe spasticity. And I don't know if you can see my hand. Am I showing on the camera? Can I show you something? Am I showing?
Yes.
Yeah, okay. So when you do, imagine if this is my foot and I've got spasticity, and you're going to test for clonus like that, and the person goes like that, and then it dies out. And if you like, the oscillation is not tremulous because they start with large amplitude oscillation and then goes milder and milder and milder, and then it stops. And that's called a dampening, if you like, oscillation. And it's not really, well, it's not an oscillation, it's a dampening movement. So remember that clonus is not tremor. And similarly, myoclonus, which is sudden jerky movements of the limbs, is not tremor because it's not an oscillation. And chorea, which I will mention again, is a sort of a random dance-like movements, which are again not tremor. So please remember that tremor is important to recognize because its treatment is completely different from the other movement disorders. The drugs that work for tremor don't work on the other movement disorders. So it's in multiple sclerosis is a particularly common condition. The prevalence of tremor in MS is anything between 25 to 58, depending on which study you read. And I'll show you the two main studies in that. One of them is ours from London, and then the other one is from Olmsted County. 25% if you do it in the general population, in the community multiple sclerosis population, whilst up to 58% if you're looking at an MS center, where I looked at this. So it's a very common problem. And as I mentioned earlier, because it's part of the ataxia, up to 80% of patients get ataxia and are going to struggle with tremor at some stage. But when you look at the Kurzke functional scale, which I've got here, it's not really a tremor-based functional scale or disability scale. It's sort of designed to see how disabled is a person without much emphasis really on tremor or weakness or numbness. And if you look at the jump between, so 5 is severe enough to impair full daily activities. By the time you get to 6, they require a walking aid. Now that doesn't tell you whether they're requiring a walking aid because of weakness or ataxia. And then if you you jump from 6.5 straight to 8.5, it's only then that it mentions some effective use of arms and retains some self-care. So by the time they started to shake, they've already jumped to 8.5. I don't know if I'm making myself clear, but basically what I'm trying to say is if you start to shake in MS, you're already severely disabled and you jump to 8.5, if not 9. So tremor is a very disabling sign and symptom of multiple sclerosis, and you'll come across it a lot. Now, how do you classify tremor? You could classify tremor according to its frequency. In MS, it's very common to get a low frequency tremor. Medium frequency would be something like Parkinson's disease, about 5 Hertz, and then fast tremors are things like essential tremor, particularly in the young. You could also classify tremor according to etiology. So you say this is MS-associated tremor, this is Parkinson's tremor, etc. You can also classify it according to the body parts. So this person has a voice tremor, a head tremor, a neck tremor. But the most important classification really is according to the state of muscle activity. So when you're coming to examine, you want to know if the tremor is present at rest, on posture, or on goal-directed movements. And that's really what's going to diagnose it for you. Now, because of all this mess in classification, the international, there was a consensus classification proposed by the Movement Disorder Society. There was a previous classification in 1998, and this is the revised version. And so basically they have this task force that looked at all types of tremor and how to really look at them and classify them properly. So again, you can see that the task force defines tremor as an involuntary rhythmic, oscillatory movement of a body part. You need to fulfill all these requirements to call it tremor. But you can get something called a physiological tremor in the outstretched hands. So make sure you remember that and not diagnose everybody with a physiological tremor as, you know, having a tremor. And basically the classification has two axes. The first axis is the clinical features of the tremor, and the second one is the etiology. So for example, when you see those patients in clinic, you're going to look at the history. You're going to ask, when did it start? How did it evolve? You know, did this take years to come to this, or over 2 or 3 months the patients become severely disabled? Is there past medical history that's relevant, and indeed family history of ataxia or tremor, because essential tremor can be familial, as you know? And then is there alcohol sensitivity? And then you look at the tremor characteristics, and I've circled that badly with red, activation conditions. So you're going to look at which body part is affected. So for example, head tremor is not going to be Parkinson's disease. It's going to be more like essential tremor, dystonic tremor, or MS tremor. You're not going to see head tremor in Parkinson's if they don't have dual pathology. And then you come to activation conditions, which is what I said is the most important part. So you want to look at whether the tremor is present at rest. Now, at this point, I would like to ask the audience. I know there are 14 or 15 of you. I know I can't see you unless I make this a little bit smaller, and ask how many people here think that MS can cause rest tremor? Hands up if you've seen multiple sclerosis presenting with rest component, you know, like a Parkinsonian tremor. Nobody. Well, that's reassuring, because you're not supposed to see that. So that's actually quite reassuring. That, and I'll tell you about rest tremor in Parkinson's, in multiple sclerosis. Yes, it's very unusual to get. It's very unusual to get a rest component. So in multiple sclerosis, which I'll show you a video of, it's mainly a postural tremor, and then it goes on in tension. Then you look at the tremor frequency, as we said. And particularly in MS, you need to look for the associated signs. So a young person who's 24 with severe ataxic tremor or an intention component tremor, you're going to want to know if that person has had MS for a while and not realized. So you want to ask for associated signs in multiple, and then you would all know about the associated signs. If the person has had optic neuritis, if the person's had numbness before, you know, have they got any weakness, any spasticity of the legs? Then you are thinking, is this MS? On the other hand, if the patient is shaking, but they've got liver failure and history of alcohol, you're going to know what's causing that tremor. Again, if you see a patient with Kaiser-Fleischer rings or copper deposition, you're going to think this is Wilson's disease. So what I'm trying to say to you, that it's obviously not in isolation, again, a bit like ataxia. And then you may want to do additional laboratory tests, and these are things like MRI scan, which is very important in multiple sclerosis, for example, a DAT scan in Parkinson's disease and stuff like that. So this is axis 1. So if you're facing a tremor in your clinic, you want to look at all of these. And then you look at the etiology, that's axis 2. So is it acquired, is it genetic, or is it idiopathic? So at the end of your assessment, you come up with, this is a person, for example, with bilateral arm tremor, no family history, with associated weakness and spasticity, and you think this is, and I've done an MRI scan, and I think this is multiple sclerosis. So I hope I've made that sort of clear, because it can be really overwhelming to just get a patient with a shake, you know, and you think, well, I think this is MS, but I don't know how to prove it. You're going to do it systematically if they only presented with tremor. So coming to talk about multiple sclerosis associated tremor, which is really why you're all here. So looking at the prevalence studies, as I mentioned to you, there's a study in London which was done by our group when I was doing my thesis, and we looked at, this is an MS unit in the northwest of London, and we looked at the prevalence of tremor in 100 patients. And the total number was as high as 58. Patients, some of these only had a very mild bilateral tremor and no ataxic signs. Patients with severe tremor were as high as 15%. So this is an MS unit. Remember, there's bias in selection, so they basically get all the chronic progressive ones, don't they? You know, the acute relapses are not going to present there. So there's a huge bias there. And then to have both sides affected, it was 36 out of those 58. Leg tremor was present in 10, which was actually quite shocking. People wouldn't think of MS as a cause of leg tremor. But there you are, 10, that's 10% of the patients I've seen had, in that unit, had MS tremor, sorry, had leg tremor. 10% of the chronic progressive MS had leg tremor. Head tremor was present in 9 and trunk tremor is 7. And then there's this very nice study actually, which was in Olmsted County, looking at the community group with MS. And you can see this is obviously much lower because this includes the relapsing remitting patients and patients who are asymptomatic. And this showed a 25% prevalence. Again, they showed arm tremor to be bilateral. Sorry, not bilateral, sorry, arm tremor being present in the majority. Leg tremor, they actually got 6%, and head tremor. They did not report on trunk tremor. But please remember to look for trunk tremor. It's most disabling. Coming to the pathophysiology now of multiple sclerosis tremor. You've all heard, I'm sure, in your module 1, from what I've looked at from the timetable and indeed from the last lecturer, that multiple sclerosis is a multifocal disease. You're going to get plaques everywhere, aren't you? And it's going to be in the cerebellum, in the pons, in the cortex, you know, you name it, could hit it, but mainly white matter. So it's a predominantly white matter disease. And whilst we traditionally all said, you know, I remember when I was in training that, you know, for people were still just about reporting gray matter problems in MS. So now we know it does hit the gray matter. Indeed, if you look at the basal ganglia, they'll be really severely affected with plaques. Nevertheless, you don't really see them presenting with gray matter issues. Now, you can get cortical cognitive impairment, but they're rare. You know, dysphasia is reported in multiple sclerosis, but again, that's rare. The main problem is white matter, isn't it? The reason we don't understand the pathophysiology so much as we understand other things is that there were no large studies linking the tremor in a population with what they found on postmortem. But that's hard to do because you're going to have a mixed, you know, if by the time they die of multiple sclerosis, well, unless they died of something else, but if they died of multiple sclerosis, you're not going to just have tremor, are you? You're going to have weakness, spasticity, you know, optic neuritis, the lot. So it's very hard to dissect a single lesion with tremor. But there are some case reports here and there. It's just that there is no major study. In general, because you're seeing the tremor like that, and action tremor. So action tremor implies it's present on posture and on movement. That's action tremor. Because it's in this position and on movement, it is very likely neuroanatomically to be related to the cerebellar outflow tract, so the cerebellar peduncles, and the connections with the thalamus. Now we know that actually the outflow to the thalamus, sorry, the afferents into the thalamus from the cerebellum are impaired in multiple sclerosis. So there is evidence that there is thalamic involvement in tremulous patients with multiple sclerosis. Now, I've mentioned rest tremor, and I wanted to mention here. So my study in 2001, published in 2001, did not record a single patient with rest tremor. But since then, I've obviously looked at this for various other reasons, because we've seen 1 or 2 patients throughout my career, and I started to look into it. And yes, indeed, there is a very small proportion of patients that suffer with something called Holmes tremor. Have you all heard of Holmes tremor? Please don't be shy, and hands up if you've heard of this entity. How many people have heard of Holmes or rubral tremor? 1. Anybody else? 2. Come on. I don't want you to fall asleep. 3. Oh, this is getting good. Alfonso, excellent. Any more? Yeah, the other name of it is midbrain or rubral tremor.
Yeah.
Yeah, you've heard of it. So does anyone want to volunteer to tell us what the features are of Holmes tremor? If you're happy to do that.
Well, it has 3 components. It has postural tremor, it has static tremor, and it has tensional tremor.
Excellent, absolutely excellent. Yes, that's right. So it is the only tremor, well, apart from drug-induced, which I'm avoiding in this talk, but well done. So you'd see it at rest, you'd see it on posture, and then you see it on movements. Now, the way it looks, it's actually quite characteristic because Holmes tremor in MS is reported, and you do need to know about it should you see it, because it implies thalamic or midbrain involvement. So it is important for localization, and the treatment is important for it. But it goes like that. So the rest component, if you can see my hands, is not like Parkinson's. It's not rolling like that. It's not that kind of rest tremor, but rather irregular. I know I said it's a regular oscillation, but in Holmes tremor, it's slightly myarrhythmic, it's called. I don't know if you can see my hand, a bit like that, with a slight dystonic posturing of the thumb outwards. So it's a bit like that, and that's at rest. And as the person puts their arm in front of them, they start to get a really large amplitude postural tremor. And when you get them to move towards the targets, they will get even worse. So if you like, it's a mixture of basal ganglia involvement and cerebellar outflow tract. And indeed, the pathophysiology is exactly that. So it's a loop that goes from the cerebellum to the thalamus, to the rubral, to the red nucleus, and then to the cortex. So it's called the cerebellothalamic rubrocortical pathway. And that is all affected. And of course, as you know from your studies, you don't need to involve all 4 areas to get a tremor or to get a sign. You just have to interrupt the neural network in one position. Now, for movement disorders, it's very important to understand that unlike weakness and numbness and optic neuritis, you don't really need to get the lesion in that area. As long as you interrupt the neural network, that's what's going to produce the tremor. So the tremor circuit involves a lot of structures, and if any of them is shortcut, then you're going to get tremor. So it's not direct, and that's why the pathophysiology is so difficult. It's not like you've got a plaque in the, I don't know, where do you want to get the plaque? Wherever you get the plaque and get weakness because of it. It's not like that. You know, if you get a pontine, for example, lesion, you're going to get internuclear ophthalmoplegia. It's ever so neat, isn't it? You just get that pontine lesion, and you know you're going to get internuclear ophthalmoplegia. You know, you get it on the optical tract, you're going to get some visual field defect. If you're going to get it in the cerebellum itself, you're going to get ataxia. With tremor, it's a neural network. It's a very large circuit, and interrupting it at any point can give you tremor. So Holmes tremor is one of those, and you can, and you can actually see it. Oh, sorry, I'm not doing very well here. Okay, and you can see it if you interrupt the circuit. Right, so that's the pathophysiology. So as I said to you before, because MS is multifocal and it can hit anything, unfortunately, it can be devastating because it practically can hit anything. You can get unilateral tremor because you've just hit one upper cerebellar peduncle, or you can get bilateral tremor because you've interrupted, you know, the cerebellum itself and both outflow tracts. You can get distal or proximal. So if you could look at my hand, and I will show you in a video, you can get it here, and that's called a distal tremor. That's easier to treat. Or proximal, where it's up the shoulder and the arm would go like that. So if you get a distal tremor, by the time they flex their arm like that, they go like this. And then if you get it in the proximal, when you go like that, it's more like a wing beating tremor, which is what you'll hear about in MS, a wing beating severe tremor. And then when you get them to do the finger nose, often they get an intention component. Contrary to the textbooks, the previous textbooks, you know, when we were training, they used to talk about intention tremor as a sign of MS. Actually, that was only 7% in my study. So usually you get a postural element more than intentional component. So the intention, pure intention, as I showed you with that older woman, is very rare in MS. It does happen. It's about 7% of the chronic progressive people, but it's still rare. More commonly, you're going to get that bilateral wing beating tremor. And then you can get an axial tremor. So that's axial meaning the whole trunk will be shaking and titubating. And I mean, a lot of you would have seen a lot of MS patients sat in their wheelchair shaking violently. Have you all come across that? Yeah? Have you all seen that? It's really, really severe and very devastating and very difficult to treat. And it's regarded as incapacitating in 15% of patients, as in it's the worst thing ever. If you do a quality of life study, like as I did in my little study, trauma was rated, people who did have severe trauma really thought it was the most disabling thing they have and the most thing affecting their quality of life. Is the worst thing that they can have. You know, if you remove the trauma, they used to say the quality of life will improve. So let's come to how you assess them. So I showed you the examination a little. So basically you examine the patient at rest, you then put them on posture with the arms extended in front of them. Then you put them with the arms flexed at the elbows, and then you do the goal-directed movement. That's the examination. But you could do scales. So say you're involved in a multiple sclerosis research study on tremor, and you want to test, for example, propranolol or topiramate or whatever you want to test. You want to assess the patient at baseline with a scale, an objective scale, and there are many. There's the Fan-Tolosa scale, there's the Bain scale, which we've developed in our study, and then there's the trauma rating scale, the TRS, and lots of trauma rating scales. As long as you choose one that you think is valid, you can then score them. Say in our study, we had the 0 to 10 scale. You could score them and you say pre-treatment, there's 7 out of 10. Seeing them 3 months after treatment, then you score them again. So it's very important to know about trauma scales if you're heading into research in particular, even in clinical practice, but mainly in research or if you're doing a therapeutic intervention. Then there are functional scales. So it's okay for us clinicians saying, okay, this person's trauma is mild, it's only 3 out of 10. And we often say that. And, you know, patients get very upset about that because they will say, well, to you it's 3 out of 10. To me, it's 10 out of 10 because I can't even lift a cup without spilling it. So 3 out of 10 is actually, if you like, this is 1 out of 10, 2 out of 10, the amplitude is a bit bigger. And then by the time you get to 3 out of 10, you're already about 2 centimeters or just under, which means when you hold the cup, you're going to spill it. So because of that, because of the impairment, or if you like, we call it impairment in trauma scales, not representing the patient's function, you want to do a functional scale. And one really nice functional scale we've done in our study, and many people do it, is pouring from one glass to another. You want to make sure the patient has an apron and you have an apron before you do that. You fill the glass with 100 mils, and then you get them to pour the glass into the other one. You can put the other one stationary and pour this one because you're assessing the one arm. And you can either measure how much is remaining in the cup or, you know, without spillage, or how much they managed to pour. So, you know, functional scales like that. There are many other functional scales like the 9-peg hole test, 9-hole peg test and stuff like that. A really pretty or very nice thing that you could do with them in clinic is to get them to draw a spiral. So I'm sorry I didn't put an example here. I don't know if I can even draw it for you on the screen, but let's not try and do something too technical. You can get them to draw a spiral starting from inside, going outside. You all would have seen this 5 times. And what you find is a patient with Parkinson's, for example, the spiral is all cramped up and small. With somebody with dystonic tremor or essential tremor, the spiral will be in the 2-7. If you imagine a clock, the 2-7 orientation, it will all be there like that. Or in MS, it will be just a disorganized spiral. So it looks ataxic in that the circles are not sort of uniform. That's if they manage to hold the pen to the paper. And my video will show this in a minute. You can do physiological studies if you're into research. That's not really useful in clinical practice. We have done it with surgical trials, but it's not really very practical. Accelerometer is a piezoelectric thing that sits on your wrist and you measure the amplitude or the frequency. And then you could do tracking devices. And the beauty of the trial, although they're hard to interpret, The beauty of them is that you can see the ataxia as well as the tremor. You can see the rhythmical movement in a tracking device. We can also see the disorganized ataxia. So, moving on to treatment, which is really the thing you're going to do as clinicians. Unfortunately, in MS, there are no large randomized controlled trials. There are an essential tremor, dystonic tremor, Parkinson's tremor, but not in MS tremor because it's said to be rare. But in general, the most important two tablets that I want you to remember, please, is propranolol if the patient is not asthmatic. Is by far the best treatment for any tremor, but particularly MS tremor. You want to make sure they're not got cold extremities and they're not asthmatic and they don't have heart failure. And if that's all right, you give them propranolol. The doses you need are very high. So we're going to talk about something like 40, then 80, then 120, then 240. I don't go beyond 240. Some centers do. I think it makes them really tired and feeling awful. So if they didn't work by 240, move on. And the second tablet that works is topiramate. Now again, in MS, if the patient is catheterized or has any bladder issues, you don't particularly want to give them a kidney stone. There's an increased risk of kidney stones with topiramate. So you want the patient to drink plenty. And it can give them depression. And again, depression is quite high in MS, so you want to be careful. Clonazepam is good in MS, but it can make them tired. The rest are waste of time. I've put them there because people try them, but they're really waste of time. So carbamazepine really makes them feel awful and it doesn't work. Isoniazid used to be used a lot and still is by some senior neurologists, but it really is. The side effects are not worth it on the liver and everything else. And then cannabinoids were tried and unfortunately have been found ineffective in MS. Sometimes your friendly physiotherapist or occupational therapist can be brought to the scene and they can give them lycra sleeve or a lycra suit, which helps some patients. It's worth a try. I wouldn't say it's sort of groundbreaking, but it can be helpful in some patients. And then we go to surgical therapy. So I'm sure there'll be some questions about that in the end, so I'll leave you some time to ask me in the end. But basically, we use deep brain stimulation surgery for MS as a palliative procedure. It can work really well if the person has a distal tremor and the person is not blind and the person has not got severe cognitive impairment or severe swallowing problems. You can use deep brain stimulation and it gives them some function back. So for example, they can dress themselves, brush their teeth, and do well. In the past, we used to do thalamotomy, and now I'm sure you've all heard that this is making a comeback with the MR-guided focus ultrasound thalamotomy. So without any lesion being made, the focus ultrasound goes from outside and burns the lesion in the thalamus. And you go for the VIM or VOP. So there's a nucleus in the thalamus called the ventral intermediate, which if you burn or lesion, then you can get rid of the tremor circuitry. Improvement in all trials or most trials will report actually 80% plus improvement in the tremor, but that doesn't translate in function. Now, I want somebody to guess why that is. So if you stop, what's the difference between stopping essential tremor that makes them write and play music again and MS? Why is it different in MS? I'd like somebody to tell me. I mean, sort of open a discussion for you guys. Is that Amin, Rabia Amin? Is that hand old, or do you want to tell us?
Oh, can you ask the question again, please?
Yes, of course. So if you did thalamotomy or deep brain stimulation, you will improve the tremor hugely by 80%, but the person still cannot function, cannot use their arm to write or play music. Why is that? Why is it more helpful in other tremor conditions? What's different about MS tremor?
Oh, your sound isn't come with me.
It's what?
The connection isn't good. I don't hear. I can't hear you, Professor.
Okay, can everybody hear me or not?
Yeah.
Okay. Can anybody else answer?
MS is progressive and it's not only affecting the basal ganglia or the structures involved in tremor. So, of course, they get weak, they've got spasticity, they've got motor function disability. So that's the reason, mainly, in my opinion. We treat one condition, but the other is still progressing or ongoing.
Excellent. Yes, so they have other deficits, absolutely. So that's one reason. But say they didn't have any of this. What's characteristic about MS tremor that I've told you about? What is it mixed with? That if you switch off the tremor with a deep brain stimulator, what is remaining there behind?
Because of cerebellar pathology.
Yeah.
Yes, absolutely. So what deficit, neurological deficit, does it give you that makes the function of the arm wrong? What the cerebellum gives you that makes the arm still not normal, even though you switched
coordination?
Excellent, absolutely. So it's ataxia, isn't it? So the problem with MS tremor that's different from all the other tremors in the world is that the ataxia is embedded in it. So if you like, the patient is shaking like that, and as they get the target, they go like this. You switch that off with the thalamotomy, they still have dysmetria. Yeah, you can't really treat that with the thalamotomy. So it's what they call an ataxic tremor. So by the time you come to surgery or thalamotomy, you have a severe tremor that is likely to be ataxic, meaning you're going to switch off the rhythm, the rhythmical activity, but you're still left with incoordination, which we can't treat with anything. Yeah. So absolutely. So that's really what's different. So in essential tremor, when we do deep brain stimulation for essential tremor, the patient can do anything you like, you know, they could write, they could draw, they could put their eyeliner on, you know, they could do whatever they like. Whilst in MS, there's ataxia also embedded. So when I select patients for deep brain stimulation, when they come to me for MS tremor treatment, you know, you try medical treatment, you may want to try wrist weights, they're a bit tiring really in MS. And then the next step is surgery. Now you want to assess the patient in terms of how much of this is tremor, how much is ataxia. And how do you think you're gonna examine that? Of course you examine the tremor, you know there's tremor, fine. So how are you gonna know if there's ataxia as well with the tremor? What other sign are you gonna look for in the arms? Anybody? In ataxic signs in the arms, from what we've said so
Is
far.
the diadochokinesis, maybe?
Perfect. Yes, there's diadochokinesia, and what's the other one?
Metric.
Dysmetria. Perfect. So basically, when they shake, so I'm going to show you here. Say this is the target, and they're shaking like that. That's shaking. But if they're shaking here like this, and they come to the target, and they're all over the place like that, going really far from the target, then they're likely to have dysmetria as well. So if you like, the amplitude of the tremor gets worse and worse and worse as the target comes on. Yeah, does that clear? Does that make sense to everybody or not really?
Yes, sure.
Yeah. All right. Okay. So let's show you deep brain stimulation. So deep brain stimulation, which you're going to come across as MS clinicians, is basically we put a little electrode here in the thalamus, and that's the electrode, and then that goes into a lead, and the lead into a wire. All this is buried under the scalp, and then the wire is buried under the skin down to a little a pulse generator, a battery. It's called the implantable pulse generator, IPG. So the patient has this, and then we switch the device on, and then the stimulation will go to the thalamus, and essentially you inhibit the function of the thalamus as if you're lesioning it to try and get the tremor under control. Let me show you a patient. So this patient, unlike the other one, is young. She's in a wheelchair. Yeah, you see that? And she's going to have MS, isn't she? Because I brought her to this lecture. But let's just show you what her tremor looks like. So I want some interaction from the audience to stop you from all going to sleep. Tell me, what kind of tremor do you see? Firstly, is it distal or proximal? I'll stop here, come back again. I'll show you
distal.
Again. Well done. Distal tremor. Excellent. Now, she may have some proximal component. I'm not sure of the shoulder, but it's mainly distal. You're right. Look at that. Yeah. And you see how she's stiffening up to stop it. Now, this is my finger. Look at how she comes. Do you see that? So what's happened to the amplitude? Let me stop. What happened to the amplitude as she reaches my finger?
It has increased.
It's really severely increased. Now, look at her holding a pen to a paper, the spiral I was telling you about. And if you look at what she's trying to do now. So we are asking her not to draw a spiral, but to go inside the spiral. Oh, sorry, that stopped. Anyway, she can't do it. This is post-DBS. This is 6 months post-deep brain stimulation. Do you see how steady she is?
Wow.
It's amazing, isn't it? I mean, she's made that. Yes. So you put she's able to hold the pen. Now, to you and I, you may think, well, you know, that's not a big deal, but to her, it's a huge deal. She is able to hold the pen and enjoy that improvement again, guys. Look at that. She's able to hold the pen and go inside the spirals. And this girl is now doing whatever she wants, really. She can comb her hair. She could just about put makeup on and brush her teeth and stuff like that. So we're coming towards the end because I want to give you some time to questions. All this time I was telling you about ataxia and tremor. I really have on purpose, well, I've not been asked to tell you about other movements, but I kept them to a minimum to the last slide. I want you all to know that unfortunately, despite the grey matter being rare, presentation of grey matter involvement is rare in MS, it still does happen. And patients with MS have other movement disorders. So dystonia can happen in multiple sclerosis, particularly paroxysmal dystonia. And that could be actually one of the paroxysms of acute relapses that you see in multiple sclerosis. And it can be actually a presenting feature. Remember that. That's very rare. But should it happen in a young person, please don't ignore it. That may well be the first sign of multiple sclerosis. Cervical dystonia, on the other hand, is more of a chronic condition. In other words, you're less likely to be able to treat it as a relapse with steroids, cervical dystonia. Chorea is very rare. And ironically, although in other conditions it's a chronic condition, in MS it can actually happen subacutely and can be treated relatively well if it's in the middle of a relapse. Myoclonus can happen in multiple sclerosis, particularly palatal myoclonus, but extremely rarely. And that's not really treatable with steroids because that's sort of a degeneration of the molar triad, if you've ever heard of that. So it's sort of a triad towards the red nucleus and the cerebellum. And really, it's not very treatable at the best of times, let alone in multiple sclerosis. And then there's something called propriospinal myoclonus, which is a rare form of myoclonus of the trunk spreading to the limbs. And again, it's not very treatable condition really, other than drugs. You can even get Parkinsonian features in multiple sclerosis. Now, that is a hard one to attribute to multiple sclerosis. There have been quite a few studies on this. And on the whole, I think it's thought to be a coincidence that a person in their... I have 2 patients with this, actually. So they have... one of them had MS since the 90s, and then more recently developed bradykinesia and rigidity, and his neurologist sent him for my movements for the clinicus Parkinson's disease, and indeed he did have both. Now, it's very difficult to know if they are related, but generally the studies have shown that it's probably a coincidence, provided you I mean, the people have tried to look at DAT scans, and they say that if the DAT scan is negative, then this must be related to MS. Whilst if the DAT scan is positive, you're looking at dopamine degeneration, denervation, dopaminergic denervation. So it's a bit of a hard one, and you're probably never going to encounter it. It's extremely rare, but I thought I'd mention it. And then also restless leg syndrome. It's more common in MS than the general population. So again, there is a bit of a link between the two. But these are not, please remember, these are not characteristic of multiple sclerosis at all. And if you see them, look elsewhere. The only one I would say is that one, paroxysmal dystonia. So that's sudden, painful, abnormal postures. So that concludes my study. Actually, I've got some references for you, which don't really show, but they will show when you have the slides. But I've left only 20 minutes, well, too much probably. You've got 20 minutes to ask questions and rest before your next activity if you have another one. So any questions? Very happy to take them.
Can I ask you a question?
Yes.
Do you hear me?
Yes.
Professor,
yes,
can you turn on the last video from the patient? She had this deep brain stimulation.
Yeah. What did you say? What was the question about the deep brain stimulation?
The question I wanted to ask if she has at the first video, I didn't mind. I watched the tremor, and then at the second video, I saw that hyperkinesia, and I think it's like cervical dystonia, or
okay. Let me see what you mean. So is that Svetlana asking?
Yeah.
Okay, Svetlana, let me get the video. So you mean there's a tilt to her head, yeah?
I think because in the first one I didn't see, because I watched the arm, and then at the second I saw a little tremor, but I saw that she had such a dystonia, cervical.
Let's have a look. I didn't think she had, but let me just double check the dystonia. You may be right. I mean, some people do have very rarely. You mean the tilt of the head, yeah?
Yeah, but I. So
you mean cervical dystonia, Svetlana, or?
The second part from the video, when we see now, because it's when she has the pen in her hand, and then it will come now. I will I will explain what I mean. Yeah, now. So we see the hyperkinesia.
Do you mean the cervical dystonia? Do you mean the neck?
Yeah.
Okay. I can see that she's making abnormal movements, but no, normally she doesn't actually. I think it's just the way she's trying to concentrate, to be honest.
Okay, because I thought
next time I see her, I will double check. No, I don't think so, but I see what you mean, though. Her neck posture is abnormal. I think it's the way you're not supposed to do this test with them sat, putting the notes in their lap, you see. So I'm naughty. They're supposed to put it in front of them on a desk so that you can see everything without them tilting. So she's sort of tilting to try and look where she's going. And she has glasses, and she's trying to look through them. So I honestly think it's just adaptive posturing rather than
an all adaptive movement. Okay.
Yeah. Good question, though. Thank you.
Thank you very much.
Any other questions?
Yeah, we have a question from Meral.
Hi, Meral.
Hi. Hi. We are also using propranolol first for the tremor. How about combining treatments in tremor approach? And we usually don't use topiramate because of cognitive
side effects.
Dysfunction. What's your opinion?
So you talking about combination therapy? So we mean propranolol plus something else?
Yes. Or any other approach? How do you approach?
Yeah, so I normally start with propranolol, and if they've got mild benefit rather than no benefit, then I would add a second tablet. You're absolutely right. Topiramate, you're right, can cause cognitive problems, but you don't need to go too high like essential tremor. So for essential tremor, you have to go up to 200. For MS, I find the small dose will work in addition to propranolol. You can use both together. And indeed, you can use the propranolol with surgery, for example. I find the others really a waste of time. So gabapentin, carbamazepine, isoniazid, all of these are a waste of time, and the patient can feel so ill with all of them. For the nighttime, if the tremor is really interfering with nighttime issues, like they can't even put their head down and they're shaking so badly, especially if there's a dystonic element, I would give clonazepam. But I would only make sure that the clonazepam is taken only at nighttime, and they understand that it's addictive in the young. They're all young, aren't they, the MS patients? So you want to make sure they understand that. But so clonazepam and propranolol together I have used. Topiramate, as you say, is not very well tolerated. It does work, it's just not very well tolerated. But I don't combine anything else. Well, there's nothing else for MS really, unfortunately.
Thank you.
Yeah.
Thank you. Thank you.
Actually, for Holmes tremor, if you ever get to see that, you can use levodopa for the rest components because that implies basal ganglia involvement, and that is 50% of patients will respond. So for Holmes tremor, not for, so for Holmes tremor in MS, I mean, which is very, very rare. I mean, you know, you can count them on your fingers in the whole world, and you can use levodopa.
Do you have patients under DBS improvement, MS tremor improvement under DBS? Do you have patients experiences like we don't have any experience DBS in MS patients?
Oh yes, of course. I mean, this is sort of one of my main jobs really is DBS for tremor and Parkinson's. For the study that I did, which is published, by the way, I don't know if I put it on the references, it's in Brain, you can have a look at it. It was on thalamotomy in MS patients over 2 years, but thalamotomy, by the time you've done 2 sides, the speech can be affected. So DBS is better than thalamotomy for MS. Now, out of the, we've published on DBS in MS tremor, you can look it up actually. It gives you 50% functional improvement only, whilst in essential tremor will give you much higher. But I mean, I probably think we have, how many would we say we have at Walton? Probably 15, 16 patients with MS. I've been there 19 years, so maybe we'll get 1 or 2 a year referrals and then accept one and decline one. So I normally try and avoid anybody with a severe proximal and axial tremor. So if the whole body's titubating, really DBS doesn't work. And if the person is very ataxic, it doesn't really work because you're not going to improve function much. And if it's a very low amplitude tremor, it doesn't work. And make sure they have good normal power, because if you're going to do DBS, you don't want them, as you said, I think, or one of your colleagues, that they shouldn't really be weak or lost joint position sense, because by the time you've got these, you can't really improve them. So we have relatively good results. It doesn't last long. It doesn't last as long as Parkinson's or essential tremor, unfortunately, because MS, as you said, is a progressive disease, and really 3 to 5 years is the maximum benefit. But patients, even knowing that, some of them go for it because it improves their dressing. Even if they can't do it, the carers can dress them easier than them beating them. You know, it's really severe. Some of them come to injury because they're hitting the wheelchair so hard. So it can be palliative and it can be really good for care. But you know, when we did the thalamotomy, patients were so much better, and yet they wouldn't use the arm. And you think, well, you've stopped shaking, use your arm. So that you need to really judge how much the person is functional before doing the operation. Ideally, you want somebody that you think will function rather than somebody who's bedridden or, you know, severely disabled. They're not going to benefit. So not put them through the torture of all of this.
Thank you.
Welcome.
Do you have any experience in patients with MS and functional tremor?
Yeah. Now that's 2 rare things, isn't it? Right. No, I haven't actually, because it was Sanya, was it? Sanya.
Yeah.
Hi. This is really interesting. I have a very high threshold to functional disorders. So we see them all the time at Walton. I'm involved heavily with them, but I tend to have a high threshold. I don't really diagnose functional unless I'm really so sure. And there are other red flag signs, red flags. In MS, because they have an organic pathology, you need to be very careful. So you could say MS with functional overlay, this is what we call it. If you like, because they're so anxious about MS, maybe they will exaggerate a bit, or maybe they've got traumatic life or whatever. But I think if you can take this from me, and I practice about 19 years as a consultant, I would say for functional patients, it's very important to win them to your side and to win their trust. And if they have a severe organic disorder they're struggling with, I think it's more appropriate to call it functional overlay rather than functional, because they know they've got a horrible disease. They don't want to be labeled functional. So the management becomes tricky if you call it functional. I've not seen it though in MS, I must admit. I've seen a lot of functional, but not much functional tremor. It's very rare. Functional disorders, yes, but functional tremor is very rare. I have seen some, and it's in MS. I've never seen it. Well, put it this way: I might have seen it and missed it. I've never diagnosed it. I might have been wrong, but I've never diagnosed it.
It just came to my mind. I have a patient who's been diagnosed with MS for 15 years, and 10 years into her marriage, her husband leaves her. And then she, of course, comes to visit, and all of a sudden she has a new onset tremor. And of course, it was really, really obvious. Of course, we did the MRI again and everything, but it was quite obvious. And it took me 2 years to convince her that it's not a new symptom, that she actually has. We have a saying in my country, it's like, okay, you're not ill, but your soul is suffering. So it's like a pain of your soul.
Nice.
So that helped actually a lot, but it took me 2 years and a lot of exercising and a lot of talking, and I was like a psychotherapist for all the time. So that really came into my mind.
Well done. You've said quite a lot, actually. So you've said how to distinguish functional from normal tremors. Now, you've said really 3 important things, probably without realizing, because you've gone through it for 2 years, so you know it like the back of your hand. It's very easy for you. But 3 things you said which are very important. Sudden onset tremor is functional. After a severe fight or argument or divorce or whatever, again, it's a red flag. This is what I was talking about, red flags. So she has 2 red flags. And the third one, you know how to do entrainment, yeah? Yeah, so you train the tremor. So for example, if she's going like this, what you do is you get the other hand to do a slow movement.
And then she slows.
She slows down or stops. So, and if you, and it's important to actually explain that to them. You know, whenever you go to functional disorders lectures, they always tell you it's important to explain it. So you say, I'm going to do a test to test how much the brain is influencing the tremor, because it's meant to be subconscious, isn't it? So you really want to disengage, that part. So you say to them, I'm going to try and stress the brain or de-stress the brain, whatever, distract the brain from concentrating on this, and by doing this test I can tell, and they will entrain. So sudden onset, abrupt onset, entrainable, distractible, and after a bereavement or whatever is highly suggestive. You're absolutely right. And how did you treat her? I mean, you should send her to a psychotherapist. You're not a psychotherapist, I presume, are you?
Yes, no, I'm not. But they are really, really reluctant because we are quite traditional, and stigma is a huge problem. I mean, I suppose it's in every country, but when you have traditional countries, it's even more. So whenever functional patients come to visit, I always say, when they ask me, okay, well, how long will the treatment last, or how will you treat me? And I always tell them, well, that's up to you. You have to just recognize the pattern and then to use your brains again, not to do it. It's really hard. So I usually spend a lot of hours talking to them when they come to visit.
This sounds good. Which country is that, Samia?
Montenegro.
Okay. They're very traditional and conventional.
Yes, very.
Functional disorders, right.
Yes, yes. So whenever we try to send patients to psychiatrists, it's, oh my God, no. So as a neurologist, we often have to treat depression and anxiety, and we actually call our colleagues by phone because we are sure that they won't go to visit. So but that's something that we actually do. We shouldn't, but we just want to help our patients.
No. I mean, it's not about should or shouldn't. A lot of countries have combined training. So I actually did psychiatry for 6 months because I was, as a trainee, wanted to do neurology. So I went and did psychiatry for 6 months to try and see.
We also have it in my country, but 20 years ago, we only had neuropsychiatrists. We did not have a neurologist. But 20 years ago, the government decided, okay, we should split it. So now we have psychiatrists and neurologists, but we are obliged for 6 months to go to psychiatry ward.
No, I chose. I wasn't obliged, but well done. I mean, I think is the right approach. It's the same brain, it's the same mind, you know?
Yes, absolutely.
We should have an open mind. And now we know that functional disorders have a lot of basis behind them as to why it happens. So yeah, well done. I'm very impressed actually.
Oh, thank you.
2 years, I would have lost the will to live, but yeah, well done. I do give them follow-up actually, joking about, I do give my functional patients at least 1 year follow-up, because otherwise they just go to other specialists and you're over-investigating, and you know, it's just, they go into trauma, more trauma from people believing, and it's easier if you maintain. I only give them a year normally, but as you're
we
right,
have 2 times a year. It's something they have right to come twice a year. So but it's exhausting. It's really exhausting.
Yes. No, well done.
Thank
any
you.
other questions, guys? You must have some questions. We've got a few minutes. No, you want to go and rest? Have you got another lecture after this? No. Oh, good. Well, have a very good evening. And if you need to ask any more questions, I think, I don't know if the organizer's gone. If you don't mind deleting the videos from the slides before distribution, would that be okay? Or is the organizer gone? I don't know. Who was it?
Franco. Maria.
Maria, is still there. She might have gone. Okay. Hello, Maria.
Here.
If you want to distribute the slides, I don't mind, provided you just delete the videos, please.
Sorry, my computer is having. Can you repeat? Sorry.
Shall I put it on the chat? Please, I'll put it on the chat if you want, but please delete the videos. Are you okay to delete them?
Yes. Yeah. I'm gonna talk to Gina or to Francisca, because I don't know actually how to delete this part of the videos, but yeah.
I mean, did you record this session? You did, yeah?
Yes. It's always recording.
Yes. So if you could just delete the videos, I'll be very grateful, because I'm not, I can't really have them there.
Okay. I'm gonna talk to them. They are like the ones that have the videos, and I'm gonna tell them to delete the videos.
Yeah, thank you very much. Thank you.
Yeah, it's okay. Don't worry.
Thank you, everybody.
Thank
Bye
you.
bye.
Thank you.
Lecture.
Thank you.
Thank you.
Bye.
Bye bye.
Good luck, Senia.